What's up, everyone? This is Jeff from Lewis Physical Therapy and Sports Rehab. So this video is going to be building off of what we did last week, which last week was how we go about setting up our weekly structure of loading for tendon management. And today is going to be a much more just overview of what goes into tendon management as opposed to the kind of like specific day-to-day and week-to-week. So that is a good video for you to watch either before or after this. This might be a little bit better to watch before in retrospect, but we're going to talk today about tendinopathy management. So this could be golfer's elbow, tennis elbow, patellar tendinopathy, Achilles tendinopathy, glute tendinopathy is another big one that we see, that kind of classic trochanteric bursitis, which is really glute tendinopathy. And then there's going to be some other uses of it as well that we're going to talk about here more than anything outside of tendons. So specifically, this is an approach that I will use also for joint-related issues, so very kind of like certain stages of arthritis or, meniscus, cartilage issues, and then hypermobility. So this is actually something I've been seeing specifically in the baseball players I treat, where a lot of these individuals, the kind of taller guys with longer arms, are naturally much more hypermobile and just do not have great local stability. So as a result, we will take a very similar approach to what we do with tendinopathy, and I've just found that they need as much daily feedback isometrically as possible. If you start doing a lot of eccentrics with some of these guys, they don't seem to respond as well as others. So the hypermobile individuals, specifically from a shoulder standpoint, in this case for baseball, for throwers, that is a very similar application I have just found, just anecdotally and personally in this case. But let's dive right into it. So tendinopathy, without going too much into the pathophysiology, we'll cover it a little bit, but if you want to kind of know a lot more kind of in-depth details, I implore you to look at the works of, Jill Cook, Ebony Rios, Keith Barr. So those are some other just big names in the kind of tendon world, the tendon research world, that goes into a lot of the different types of tendons, the reactive phase, dysregulation or disrepair, degenerative. So just kind of that kind of different continuum of tendon pathology more than anything. But when we're going into kind of how we're identifying a tendon more than anything, so again, a tendon is that connection between muscle and bone more than anything. Typically, these injuries are much more at the epiphysis, so right kind of where that tendon goes into the bone. And the kind of classic presentation that we see here is, warming up is not comfortable for a lot of these individuals. It feels achy, stiff, and once they get warm and they start working out, they're usually in a good spot. And then that pain will either come back after they cool down or 24 hours after, which is very similar to what we see for our kind of, arthritic pathologies as well. That 24-hour after period is going to be a big part of how we kind of identify what load is too much or too little. But going right into it, whenever we are talking about tendon management, this should probably be first actually, is we have to load, and load. The worst thing you can do for a tendon injury is completely rest more than anything. And what's going to happen there is when you rest, you are going to essentially detrain that tendon. And this brings up a concept we call stress shielding. And there's a couple different concepts that go into kind of why these tendon injuries happen. Stress shielding is essentially, your tendon is this kind of, you can see on the lines outside here, this kind of nice fibrillar pattern like that. And you have this part in the middle. It's almost like the hole of a donut that gets some just really kind of not good tissue laid down. And as a result, that tissue cannot withstand as much mechanical load or tension. So as a result, the stress goes to other parts of the tendon. Now, the whole concept of tendon rehab is, how do we go about building greater capacity in that tendon? And there's a couple schools of thoughts where the concept of, again, stress shielding is when you accept the load, the healthy part of the tendon literally shields load from going into that damaged part. So the whole goal then we do is we're trying to promote stress relaxation, which is essentially relaxing the healthy part of the tendon to get load into that injured part of the tendon. That's one school of thought. It's a bit of a newer concept school of thought. The other kind of school of thought of how tendons kind of go about healing is, do we necessarily actually get load into this injured part, or is it that we just kind of increase the capacity of the healthy part around the tendon to better withstand those forces? And I think it's a little bit of both, but I do tend to lean a little bit more towards this stress shielding, stress relaxation concept because of what I've just seen from a treatment standpoint, which we're going to get into. But you have to load, and it's important to keep pain at a sub-maximal threshold, so less than a 4 out of 10. It is not realistic for tendons to do things that have no pain at all. If you have no pain, you're probably not loading it enough. Tendons need load to adapt. So we want to find that threshold for us to work and settle into more than anything. So that's the first things here. The third part here is tendons take time to adapt, because historically these tendons are chronic injuries that go through periods of recurrence. They're painful, not painful, painful, not painful. These take time to adapt. So what I tell people that come in with a chronic tendon injury is, do not expect this to be fully resolved in 4 weeks, 6 weeks, even 8 weeks. They should be a lot more functional at that 8-week mark, but there is still going to be tendon adaptation that is occurring throughout that process. And that's why, even when someone is back to their full activity, sport or whatnot, they have to continue loading that tendon appropriately. So that's just one thing to be very mindful of. And the fourth consideration here is we have to address the workload. So what I mean by that is, if jumping and running is the main provocative maneuver for someone with Achilles tendinopathy, patellar tendinopathy, well, we need to see, okay, can they even tolerate those activities, running, jumping, and whatnot, at a lower threshold, lower workload, or do we need to completely remove it altogether? But again, completely removing the main provocative factor, but we are still loading it appropriately. So again, that's where addressing workload comes into play. And that's another consideration when we get back to reintroducing those activities, is that we do not want to go from like kind of nothing to a bunch of stuff right away more than anything. The way that tendons typically get irritated and overloaded is we take intensity, volume, and frequency. I know it's a little bit of an angle here. And it's either one of these gets ramped up too soon, or it's sometimes a combination of all three together more than anything. You take the person that has not been running in the last 3 to 5 years, and they decide, you know what, I'm going to get off, I'm going to get going, I'm going to start training for a marathon and whatnot. And now it might seem low threshold, but their intensity relative to what they've been doing is higher. Their volume of runs on a daily, weekly, and monthly basis on more macro level are higher. Their frequency, they haven't ran at all. Now they go to running 3 to 4 times a week. It's higher. So that's kind of a little bit of when a lot of that comes into play here. But you do want to be mindful of all three of these, and that just kind of goes into questions that we ask people. So again, just good tips of what I've found of how to navigate tendon management from a clinical standpoint, and just really just good patient education more than that's the important thing. Like someone has a cranky tendon, like golfer's elbow, patellar tendinopathy, you cannot tell them it's going to be good in 2 weeks. They might feel a little bit better, but they're still gonna feel it if it's a true chronic tendon injury. So that's important, just kind of, again, setting the stage and the expectations of what the patient should expect more than anything, okay? So coming over to the loading scheme here, and I talked about this a little bit more in my last video on a weekly structure. We're gonna kind of just go through the general progression here. In general, for tendons, we generally have a phase starting with low intensity, long duration isometrics, into a strength phase, and then into more of our elastic energy storage and transfer phase. We're going to go back to here, but the reason this is the last phase is the whole job of tendons are like a spring. So the whole goal is their goal is to essentially to absorb energy and then dissipate it more than anything. And that brings up the concept of tendon stiffness, which, again, tendon stiffness is the ability to resist deformation essentially under high load. So your ability to, when you're landing or you're going down into a jump, to absorb energy appropriately into that tendon, and then being able to then disperse it to essentially perform a upward jump more than anything. So this is really the tendon stiffness phase here. A lot of times people kind of say, oh, we're working tendon stiffness in this low phase, things like that. But we're really not. We're starting to get to it in the strength phase, but when we go up to this low intensity, long duration isometric phase, this is predominantly pain control, motor control, more awareness, cortical inhibition. We're addressing that. So cortical inhibition just means in these chronic tendon injuries, there's literally a brain component that the brain kind of says, hey, I don't want you using that tendon. So we're using this to kind of get the brain to kind of reset to a degree, reset that neural pathway of saying it is okay to do this and just get them more confident in it. So the low intensity, long duration isometrics, I'm generally having people do these 2 times a day. We're going for some longer sets, 4 sets of 30 to 45 seconds. This part here is important. Tendons, when they are cranky, injured, whatever you want to call it, do not like high intensity or high velocity jerk movements. So that quick, like that, which is, again, a counter movement dropping down quickly before they go up. So what we do is we say, hey, I want you to get to 30, 40% intensity. But it's a 3, maybe up to 5 second ramp up to that intensity. It's not a 3, 2, 1, go right to 30% effort. We're gradually building up. And that's a little bit of a diagnostic component to you, where like if they try to do that quick ramp and like, oh man, that does not feel good. Again, that's just pointing you in more direction. This is likely that tendon is not able to really accept load quickly through there more than anything, okay? So again, 3 second ramp up and then a 3 second ramp down. So it's not just get to that intensity and then drop off quickly. You're kind of slowly ramping down. So we're going for some long duration here. You're probably going to have 30 seconds to a minute, maybe upwards of 2 minutes in between sets. And once you start giving more intensity, we're going about 30 to 50% intensity, and we are going in minimally provocative position. So that's important. So if I have someone that is dealing with a patellar tendon issue more than anything, I'm not going to be ripping isometrics at a 90-degree or more knee flexion position. We're going to probably start in that mid-range, 45 to 60 degrees, maybe at most, and we're working in that range, allowing them to get in a position that is not provocative, still working under this pain threshold, within this pain threshold, but allowing us to get some load into there, okay? So that's our first phase there. And that's going to differ, the length of that's going to differ for each individual more than anything. Now, you'll notice, so again, going back to that 24-hour rule, if you are doing this and 24 hours after they do it, they're like, man, I am lit up today. You went too high, you drop your intensity, or you drop your volume, or you give them more rest in between more than anything, okay? So that's this first phase. The strength phase, so that's our next phase here. We are going this one time every other day. These days in between, we're probably doing a combination of these long duration, low intensity isos, maybe only once a day though. We're starting, we don't overload, but that's what we're kind of going from there. This is the heavier, slow resistance phase, so more isotonic through the range. We are still doing heavier intensity isometrics at those different angles. We're getting upwards of probably 60 to 80% intensity, so a lot higher. And this is where we're getting our eccentric work in more than anything. It could be eccentric only. It could be eccentric only. It could be super maximal eccentrics. Or a lot of times what we'll use is a kind of eccentric, slow eccentric, and then a slow concentric phase. So that's just things to be mindful of. The eccentric is, again, we are just trying to promote more tendon structural adaptations to get that tendon ready to absorb load in the next phase. So again, that is our strength phase there, one time every other day. So depending on the individual, you're going to get 2 to 3 times at most a week of that strength isometric. The last phase here is our elastic energy storage and transfer phase. Again, that kind of that tendon spring component. This is our RFD, rate of force development component. So, thing I do with throwers, say they're out in front, we're doing more kind of FDS finger isometrics. We've done this kind of slower, heavier resistance at this point, and now it's going to be at 80% minimum, so 80 to 100%. It's going to be a 3, 2, 1, immediately build up right out of the gate up to 80 to 100%, over 3 to 5 seconds, and then relax. So that's our RFD. Then we're going to do some of our plyometrics, our jumps, and then our kind of running, throwing, sport-specific progression. So again, this is like what I want you to also be mindful of is it's not exactly always just boom, boom, boom. It's a little bit of like, it's a blend between the two components. Once I get to this phase, there's still stuff I'm doing in the strength phase. You cannot let the gas off of this. And that's where I kind of employ you to go back to my last video and see how we break that down in a weekly structure. But again, this is a really just good overview and general overview of how we go about a loading scheme for isometrics. This looks different for everyone. This is a framework. Do not have to just go like this structure is not the end all be all. I play around with this even in my daily practice, but this is a general framework we then build off of more than anything. And again, I have found really good application in these individuals, the kind of joint-related pathology, so your arthritic changes, meniscus, cartilage, and then our very hypermobile individuals that need a lot of feedback. One thing on that is probably worth another video at another point in time. These very hypermobile individuals, so shoulder specifically and elbow, but shoulder a lot of times I see this, I might not really get to the point where they might not be doing much eccentrics. It's going to be a blend more of anything of a blend of these kind of lower intensity isometrics from a daily standpoint of driving more just feedback into that shoulder from the brain of, hey, tighten up there, and then some heavier intensity strength isometrics from an arm care standpoint. Again, I only say that because I have just started to see that trend a lot over the last couple months with some of the patients that I've been working with, and they seem to respond really well to it. And listen, that might change based on what we see in the year from now and whatnot, but that's just been one thing I've started noticing some trends in some of my patients. So again, good overview on tendinopathy management. This is really the big thing to be mindful of. I cannot stress this enough. Do not rest. Find an appropriate way to load right out of the gate. You have to be starting to do stuff. It might only be 10% effort, but that is better than nothing, and it's going to put you on the right path for a good, good outcome from a rehab standpoint. So if you're dealing with any of those kind of tendinopathy issues, whether it is an Achilles, patellar, golfer's elbow, tennis elbow, and you have questions on that, drop them below in the comment section or subscribe to our channel for more content like this.